We don't have. Good morning, everyone. Welcome to the December 2024 joint meeting of the Incarceration Prevention and Reduction Task Force, Behavioral Health and Legal and Justice Systems Committees. This is a quarterly event that we hold together. I'm Stephen Gockley. I'm a co-chair of the Behavioral Health Committee with my esteemed colleague, Dan Hamill. And we're here with Legal and Justice Systems co-chair, Raylene King. I'm going to open, as usual, with our land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. With that, I'll call the meeting to order. I just want to note for everybody's information that as a joint meeting, this has also been officially noticed as a special meeting of the entire Incarceration Prevention and Reduction Task Force. And that limits us in terms of final action to only the committee business that's identified on the agenda. I don't believe we have any action items on the agenda, but just wanted to note that limitation because of the structure of the meeting and the attendance that we have here today. Because especially the Behavioral Health Committee has added some new members, I thought, and Dan agreed, that it would be useful to do a quick round of introductions. If you could, when I call on you, give your name, your affiliation, and which committee, if either, you're connected with. Peter, I see you up in my upper left. Why don't you start?
Hi, I'm Peter Fraser. I am co-chair of the IPRTF and on all the committees.
Thank you. Arlene? You're muted, Arlene.
Oh, okay. Can you hear me now?
Yes.
Okay. I was co-chairman of the Law and Justice Committee with Raylene last year, at last go round, and now I'm on the Behavioral Health Committee, which is my specialty. I am working part-time as a supervisor training counselors that are new.
Thank you, Arlene. Dan?
Yeah, thanks. Dan Hamill, Bellingham City Council President and co-chair of the Behavioral Health Committee, along with Stephen Gockley. Good morning, everyone.
Stephanie?
Stephanie Kraft. I'm the Superior and Juvenile Court Administrator, and I'm on both committees as well.
Thank you, Stephanie. Raylene?
Raylene King, Whatcom County Superior Court Clerk, or County Clerk, I should say. And I'm a chair of the Legal and Justice Committee and a member of the IPRTF. Thank you.
Thank you, Raylene. Tori, I'm sorry.
Hey, good morning, everybody. Tori Sandos here. I am a substance use disorder professional and licensed independent clinical social worker, and I currently work out at Whatcom Community College, where I coordinate and teach courses to teach students how to be addiction counselors. Thank you.
Thank you, Tori. Deborah?
My name is Deborah Hawley. I've been on the main task force. I think I'm in my, can you hear me?
Yes.
Okay, I think I'm in my 6th year. I was on the Legal and Justice Committee up until last year, and now I'm on the Behavioral Health Committee. And I represent the consumer role for the task force in that my son has been incarcerated in the Whatcom County Jail and many other places for the last few decades. So that's what I do here.
Thank you, Deborah. Mike?
Good morning, Mike Hilly, Whatcom County Emergency Medical Services Manager, longtime paramedic. Been on the IPRTF for coming up on 7 years, and then member of the Behavioral Health Committee. So good morning.
Thank you, Mike. Danny?
Good morning, everybody. My name is Danny Carroll. I'm on the Behavioral Health Task Force. I'm the Bachelor of Social Work Program Director and Faculty at Whatcom Community College.
Thank you, Danny. Birdie?
Good morning. I am Bertie Safford. I'm a retired family physician in Ferndale, and I'm on the IPRTF and the Legal and Justice System Committee.
Thank you. Ying?
Ying Wu, I'm a retired family physician, now an intern at the Chuck Nut Health Foundation, and I am on the Behavioral Health Committee.
Brian?
Brian Estes, I'm on the board of the National Alliance on Mental Illness, the Whatcom County chapter. I'm a member of the Behavioral Health Task Force, and I'm also on NAMI Washington's Public Policy Committee.
Thanks, Brian. Caleb?
Hi, I'm Caleb Erickson. I'm the Chief Corrections Deputy for the Sheriff's Office. And I don't think I'm on the committee, but.
Honorary member. Chad?
I'm Chad Avery. I'm the Behavioral Health Specialist with Whatcom County Juvenile.
Thank you, Chad. Maya?
Maya Vanya, Whatcom County Defender's Office. I'm on Law and Justice.
Judge Jones?
Hey, good morning. I'm Judge Evan Jones. I'm a judge with Whatcom County Superior Court. I'm the court's representative on the IPRTF, having taken that role from Judge Freeman, who preceded me. And I am on the Legal and Justice Subcommittee, and then also we have a pretrial processes work group that I help with.
Thank you, Judge Jones. Steve?
Steve Larson, community paramedic for Bellingham Fire Department.
Thank you, Steve. Eric?
Good morning, everybody. Eric Peterson. I am the field administrator for the Washington State Department of Corrections. I cover Snohomish County North and then out to Clallam and Jefferson County. And I'm on the Legal and Justice Committee.
Thanks, Eric. Jake?
Hi there, Jake Webush, Administrator for District Court and Probation. Nice to see everybody.
Heather? You have a moment?
Hi, everybody. My name is Heather Flaherty. I'm a co-chair of the IPRTF. This is Booker, and really happy to be here today. Thank you.
Thanks, Heather. Sheriff Tank?
I'm Donnell Tanksley, the Sheriff of Whatcom County, and I'm on many committees.
And Melora?
Good morning, everyone. Melora Christensen, Whatcom County Health and Community Services. I'm the Response Systems Manager and a licensed independent clinical social worker.
Eric?
You're referring to me, Eric Ritchie, Whatcom County Prosecutor.
Thank you.
And I don't know why I'm not on the screen.
Your camera is not on, Eric.
Jill here. Eric, you're currently attending as an attendee. You need to promote to panelists to share
There
your
we go.
video.
And we're skillfully supported by our staff assistants, Jill Nixon and Jenna Jernan. So we also have two new members to the Behavioral Health Committee, neither of whom are here yet, but one of them at least may be joining us. Jen Lockwood, the Executive Director of Bridget Collins, is sliding over to Behavioral Health. As you know, Bridget Collins is a victim support organization, so that adds a different perspective to some of the work both committees have been doing, but especially behavioral health. And we've been fortunate to recruit Amy Hockenberry recently of the Whatcom County Health and Human Service or Community Services Department, now working for the Healthcare Authority. Amy is an experienced health professional, public health professional, and will add a lot to our conversations as well. So the first item on the agenda has to do with block grant money for juveniles. And Raylene, I don't know if you want to introduce this or if you want Stephanie just to go right into it.
Well, I think Stephanie's introduced herself. So Stephanie Kraft, I'm going to let you go ahead and take it away.
Thank you. We received some funding through the block grant to start a behavioral health, to hire a behavioral health specialist for juvenile court. Chad Avery, who introduced himself earlier, and he has a PowerPoint presentation for you all to share what we've done to develop the program and kind of where we're at with that funding. We started officially in August is when Chad started.
All righty, I'll take it from here, I guess. Good morning, I'm Chad Avery, and I'm going to tell you a little bit about myself, and then we'll go into what got me here and where we're at together. So I'm going to go ahead and share my screen. But first, let me tell you a little bit about myself. I began my career in Knoxville, Tennessee in 1996 when I was just 24 years old. Working directly with juvenile offenders and at-risk youth in clinical and correctional settings. And in 2007, I relocated to Port Angeles, Washington, where I secured a position as a juvenile corrections officer with Clallam County. There, I advanced through the ranks and eventually became the corrections manager, which included my dual responsibility as the CRC coordinator. And then in 2022, I moved to Bellingham, where I was hired as a supervising juvenile detention officer. And then most recently in August this year, I started my role as a behavioral health specialist for Whatcom County Juvenile Court, supporting our newly formed opioid outreach services program. Can everybody see my slideshow? No. How about now?
There they are.
All right. There we go. So there's my journey, and that's why I'm here. But why are we here, and what's the reality we're looking at today? I'm going to try and describe the situation that we're in. Youth often become involved in the juvenile justice system due to a lack of community-based resources and treatment options. And in many cases, their involvement is related to minor non-violent offenses, including civil cases such as at-risk, chins, and truancy matters. We have over 400 youth on the civil side of things, and we're working with them and their family, their whole entourage. Many of the youth we serve are non-offenders and are at a significantly higher risk of having mental health or behavioral disorders than the general youth population. And many of them will also develop a substance use disorder. Data tells us that drug use rates increase significantly between ages 12 and 19. The opioid crisis was dramatically impacted Whatcom County, and the needs of our young people have become more acute in recent years. Primarily due to easy access and low cost of opioids like fentanyl, the county recorded 136 overdose deaths across all ages last year, making a 43% increase from 91 in 2022. Inconsistent services, bureaucratic barriers, and a lack of resources have challenged our efforts to meet the needs of the vulnerable population we share. The juvenile division of the court usually receives only small portions of larger general contracts for crisis services in detention, and there is limited and decreasing support for youth experiencing crisis or trauma within the community, factors known to contribute to poor mental health, homelessness, and a higher likelihood of substance use. Now, the great task before us, our work, the challenge, is in providing outreach and engagement services for youth and young adults involved in the juvenile court system, and lowering the risk of opioid and substance use disorder among youth and young adults facing various stresses, traumas, and anxieties. What we do as soon as we get youth in our door is we're assessing them from the moment they get here and referring them to services that they need, with the goal to reduce recidivism. That's our call to action, and we're answering the call. To rise to the challenge, our department's laying a firm foundation for a behavioral health and opioid outreach program. Our primary goal is to empower young people and reach their full potential by providing safe, personalized opportunities for growth that embrace their unique needs and aspirations. Our program focuses on case management, resource navigation, and community engagement, aiming to significantly benefit Whatcom County through harm reduction and intervention. By improving coordination, promoting advocacy, and expanding outreach opportunities, we can more effectively connect young people and their families with vital resources and establish clear referral pathways. Now, in the spirit of harm reduction and intervention, our response is we've been collaborating with community-based treatment providers to support young people seeking mental health and substance use services. Working with the court, probation, and detention, we're implementing risk management and crisis intervention strategies, assessing individual needs and resources to determine effective action steps. We're building strong relationships with community partners, acting as liaisons and advocates between youth and available supports. We're leading a weekly outreach class in detention, participating in a monthly ride-along with the LEAD program, and offering access through office visits, Zoom, FaceTime, phone calls, and text messaging. Lots and lots of text messaging. Additionally, we're conducting school, home, and community visits, organizing coaching and mentorship activities, and attending court hearings to foster positive outcomes. Our behavioral health program and outreach program launched in August this year. Since its inception, we've identified 43 distinct young individuals averaging 10 new referrals each month. Among these referrals, 67% were for mental health services, 35% were for substance use treatment, many who have co-occurring issues. And additionally, 44% reported using opioids. 35% participated in at least one session at the weekly outreach training class in detention, and 12% were assigned an involved mentor. These numbers are now outdated because I started preparing this presentation late last week. As of this morning, the number 43 shot up to 50, and the referrals keep coming in. A commitment is action in the direction of what you care about, even in the presence of obstacles. Our program is dedicated to promoting a healthier community in Whatcom County by actively encouraging youth and young adults to pursue treatment. We're committed to improve access to services and eliminate barriers that prevent engagement in recovery programs, equipping them to succeed and helping them move from surviving to thriving. The principles guiding us to equip young people to succeed are empathy, quality, unity, integrity, and professionalism. Empathy, we want to genuinely understand and address the needs of young people. Quality, we want to deliver valuable, evidence-based services with high standards. Unity, promote equality and teamwork through collaboration. Many voices, one message. Integrity, we want to be respectful, honest, responsible, and good stewards. And professionalism, we want to stay competent, relevant, reliable, and customer focused. The meaning and purpose of our work, our mission then, is to empower young people to become their best selves by equipping them with personal, social, and community assets that will benefit their lives. And the impact we want our work to have on the world one day, our grand dream, the vision, is a community free from crime, violence, and addiction, where every child and family can live a productive and fulfilling life. We're taking bold steps to do the right thing right now, but we can't accomplish this alone. To effectively meet our increasing and complex caseload, we need to hire more talented, qualified, and passionate individuals. We don't have the funding for this. Currently, our program is managed by Stephanie Kraft and operates as a one-person show. We view this as an exciting legacy project for the future of Whatcom County, and we truly are grateful for the opportunity to lead it. And we're committed to creating a positive impact that will benefit the community for years to come. We hope to one day have the funding to take on a mental health clinician and at least 1 or 2 additional behavioral health specialists. But as of right now, this is where we're at, and this is what we're doing. Thank you. And you can contact me or Stephanie Kraft with more questions, or if you have any curiosity that you would like to get answered. Thanks.
Thank you very much, Chad. I appreciate that background information. I'm going to open it up for questions in a moment. Could you tell us the source of this block grant money, the amount we have, and the duration of the grant itself?
It's a BHO block grant, and I think it's 135,000, somewhere in that area. I don't have that in front of me, but I think that's about the target that they gave, and it's funding my position right now and all the other efforts that we're trying to do.
Great, thank you. And I think Melora's in line to add a little bit of
Yeah,
detail.
the funding for this position comes from the North Sound BHASO and is part of a large SABG grant that the health department manages. So Chad's position is one of multiple positions, and that is ongoing funding that will be received.
Thank you, Melora. Questions for Chad, Melora, Stephanie, or thoughts? Okay, Peter, you're first.
Thank you so much for your presentation and the good work that you're doing. I noted that one of the challenges you listed was bureaucratic barriers. While there's not much we can do about those barriers at the federal level and little at the state level, we are all here together today. And I'm curious what sort of barriers that you're experiencing here, without getting yourself in trouble now, that we might be able to help with. I mean, that is one of the purposes of these meetings that we attend. We're all here together, and we want to see you succeed. So I'd love for you to give that some thought, and if you have anything that we might be able to do to help lower those barriers that I think we all experience and know that really harm our outcomes, I'd be very interested to hear those. Thanks.
Sure. Yeah, I think when different organizations are siloed and they have their own policies and procedures of doing things, we tend to create the barriers unwittingly. And, to get specifics, right now, one of my biggest struggles is dealing with insurance. So there seems to be very particular guidelines as who gets insurance when and what that insurance is good for. And a lot of the times we're running into these complex cases where it's not very practical. You either have too much insurance or you don't have enough. So that's one of the things that I can come up with off the top of my head. That's in my opinion, a bureaucratic struggle to where you can't whittle it down. It's just this broad brush, and there's no other recourse to take. It is what it is. So those kind of things is what I was aiming at.
Pardon me for my ignorance, but what sort of insurance coverage are we talking about here?
Well, if you have private insurance, you don't qualify for certain services that are out there because it's too much. You can't get a wraparound service. You're not. You can't get WISE teams to help you out. And some of our kids are in that situation, and others don't have enough insurance, and it's a big hurdle and time waste to try and get them that insurance, because Monday becomes Wednesday, becomes Friday, becomes Monday, and weeks could go by before it's resolved, and then we're dealing with another issue. So it's timeliness and convenience and being transparent and understanding and knowledgeable about the different procedures and processes that you're not privy to until you have to be. And so it's a learning curve, but there's a lot of red tape out there. Of course, everybody's aware of that.
Thank you, Chad. Dan?
Yeah, thanks, Chad, for the presentation here this morning. What you just described seems absolutely backwards to me in terms of getting kids into the help that they need by having a too little or too much kind of landscape. It just seems like it's really we're doing, not we, but the system is doing a disservice to these kids. This task force traditionally has focused in on people that are in the adult system, and there have been several of us over the years that have really tried to make inroads into into youth prevention models, because when they get to the Sally Port at the jail when they're 18 or 20, it's too late. It's really hard to undo that work. So I guess my question is, you had mentioned a few points of entry, but I just want just a little bit more information on that would be helpful for people to access.
Like how we get them and start working with them.
Yeah, yeah. What's the front door for people?
A lot of them come through referrals through court staff. Most of the 50 that I pointed to came that way, and they're there not only because they're getting locked up in detention. Again, most of them are non-offenders. They're coming in contact with the court for various reasons, and because of that, they're being identified as needing services. So court staff are writing out referrals and passing them to me, and from there, we try to do our best to assess what they genuinely need, and then find the best course of action to take with each and every one of them.
Thank you.
Deborah?
Yeah, I'm kind of echoing what Daniel was saying. My thoughts were, oh, by the way, thank you for the presentation. I think it's really great that juvenile offenders or juvenile non-offenders already in the system, that this topic is being brought up, because we all know that the earlier the intervention, the more likely that the chances increase of stopping that problem in its tracks, if possible. But it's really sad to me to find out that there is very little funding for this program. And yeah, it makes me think about the school to prison pipeline and that trajectory where, Daniel was kind of referring to, you start on this path at a young age, and if there's no intervention, you sadly go right on up into adult criminal justice system, and from there it only gets worse. So mine was just a comment, and thank you very much for your presentation and bringing light to this situation.
Thank you.
Thanks, Deborah. Arlene.
Yes, thank you very much for the presentation. It was, I know it's very much needed, but I wanted to mention that in order to have anything that we want, we have to have funding. It's crucial. There is an obstacle of believing that there is no funding, but the fact is there is funding. You have to find it.
Right.
I spend a lot of time researching where does the money come from. It comes heavily from the state and not enough from the federal government and from grants that you find. So those are the what I saw with the sources. And it's not like I wanted to research money, but I had to.
Right.
Because yeah, that's it, the key, right? Teenagers are very resistant, and you probably have run into that. And it means very often that we need family counselors, counselors who specialize in family problems. And do you have that?
Not currently, and you're hitting on a big aspect of what we do. We work with the families as well as the youth, so it's all encompassing. It's not an isolated event, you know, offender and non-offender alike. We're working with the whole family and anybody in their entourage, and you know that can create a complex and tricky caseload, but hopefully that's where you can see the dynamic change in that child's life and then that family's trajectory, and they're not going to go back and further into the system or get locked up. So and that's the hope I have working with juveniles, is that they're still juveniles, and you know we have until they're 18 or 21 if they're still in their jurisdiction with probation, to stop and change course and put them on a better trajectory. So that's what puts my feet on the ground every day, and I think that's the spirit here in the building, in the department I work in.
Well, that sounds good, and I just wanted to point out that many times the source of the problem is in the family. Sometimes it isn't, but usually it is.
Right. And when you meet the child, sometimes they're the most thriving one in the family, yet the child's behavior is the one getting addressed. So yeah, absolutely.
Thank you, Arlene. Tori.
Yeah, thank you. Thank you for your presentation, Chad. Enrolling 50 youth as of today is a spectacular feat, and I just want to mention that. I have a little bit of experience in this area. One of the things that I recognized is that the pandemic sort of, we just lost all of our touch points with youth. And in my past experience providing SUD treatment for youth and also participating in truancy, it wasn't the truancy board, but it was like the next step before truancy board. So we interfaced a lot with schools. And so I am curious to know what your plans are with regard to getting in sooner before they get to the detention phase for these nonviolent offenses. And what kinds of, I mean, I know that Northwest Youth Services provides a lot of outreach, and I'm wondering what kind of collaboration you may have going on with them.
We're collaborating some with them. Again, I've been in this position for just over 4 months, so I'm networking like heck. I'm going into the schools all the time. My face is becoming more and more familiar with all the staff in the different places, and you know, we're going to dream big. I'm sure next year things that we're doing are things I'm not even thinking about or understanding today. So getting in there and preventing them from even getting close to the system would be great. And having a familiar face. A lot of the times, part of the outreach program of Up in Detention is so that they have a familiar face so they can talk to me when they're walking down the hall here, or if I'm introduced to them, it's not just a cold call. It's somebody, oh, I know Chad. Yeah, of course. And they'll be more willing to engage. So going to the schools, going to the different community partners, meeting and greeting and understanding their processes and how they do business is just going to help us do our work even better. So yeah, I'm out there shaking the bushes all the time and seeing what falls.
Thank you for that. I just want to I have one more quick question. If we, as providers, identify youth that are at risk, if we've got a family that comes in and says, I don't know what to do with my kiddo, I need some help, is there a direct referral process to your program?
You can give me a call and we can walk through that for sure.
Okay. All I got was an email on your presentation. So
okay. Yeah, I'll share out my I'll give you my phone number right now if you want.
Sure.
778-5515.
5515. Thank you.
You bet.
Raylene? After Raylene, I'm gonna hold the questions just to honor the time we'll need for the rest of the agenda, but I have a comment after Raylene quickly. Go ahead, Raylene.
Thank you, Stephen, and thank you, Chad and Stephanie, for putting this together. It was very valuable. As I echo some of what Dan said earlier, is the task force has been primarily focused on adults, but as we look into this further, we really need to work on prevention, and starting with the youth, I think, is imperative. I know years ago, when we were working on the Ann Deacon Center for Hope, I had asked Anne about the children and how we could work on some of that. And she said, unfortunately, there's a lot of red tape to get through that. Even with like the CQ unit at the hospital, when children are admitted for problems, they're housed with the same people that the adults. And so this is an ongoing problem that this county really needs to look at. I think the more we focus on the juveniles and in Superior Court, a lot of times you think about just the criminal stuff and they forget that we're dealing with at-risk youth and dependencies and children in need of services, as well as minor guardianship. And all of that affects what you guys are doing and the work that's being done and those children that don't get those services early on are the ones that we're dealing with in the criminal world. And so it's imperative that we really try to support and help figure out whether it's just working on trying to get around the insurance barriers or make sure that there's more support for these types of programs. I really appreciate the presentation. Thank you.
For sure, thank you. And you just triggered a thought in my head about the first question was what are some of the bureaucratic barriers? And liability is a whole other ballgame at the juvenile level. So to be innovative and creative with solutions, a lot of times we get hamstrung because of liability issues. And so that's a constant struggle to navigate that obstacle course. And but that's also a good challenge because, you set a precedent. Hopefully you can keep that precedent and build on it. So thank you.
Chad, thanks again for being here with this information and for all the work you've already put into starting to push this ball up the hill. It's obvious from your own description, you're at the very beginning of building out a response to the juvenile population in need. And I'm just thinking this topic, as Raylene said, has come up a couple times, quite a few times, and carries interest across both of these committees. I'm wondering if maybe in the next quarterly meeting or the one after that, we could have you and Stephanie back, because obviously you're going to be building out a plan of action and you're going to be developing your resource base and have some insights that you've gained in the next few months. And if you could update us sort of as you go, service-wise, funding-wise, network-wise, that would be of interest to you. So I just throw that out as an idea and ask you to consider that possibility. We'll try to give you some lead time for that.
Thank you. That would be wonderful. Thank you.
Great. Okay, moving on in the agenda. A number of meetings ago, Dr. Wu identified a reentry program in Los Angeles that had quite a track record of success. It's called Homeboy Industries. And there was interest in the Behavioral Health Committee, at least, in finding out more about that. In the intervening time, Dr. Wu has actually visited Homeboy Industries while he was in LA on other matters. And we found that they actually have some connected groups in various other locales, including Skagit County. Dr. Wu, Mike Hilly, and Brian Estes, I believe, had some contact with the Skagit people. So I'd like to ask Dr. Wu and Mike at least to fill us in, update us on the information and their sense of the program model that Homeboy Industry affords for reentry services. Dr. Wu, I'll turn it over to you or to Mike or whoever you'd like to start this out with.
Yeah, I thought I'd go ahead and go first. I'll talk a little bit about Homeboy in general, and then Mike has more information about the local Skagit program. I'll just start off by saying I really appreciate going after Chad, because I think what you'll find as we go through this is that there are just so many overlapping areas between this work that Homeboy does and the needs that Chad's identified. It's a little difficult for me to talk about this subject because this is a prison. It's a reentry program for folks who've been incarcerated, primarily gang members. It's a program that was started by a Jesuit priest and is faith-based, and I'm not a content area expert in incarceration or law enforcement. I know a little bit about gangs. I know a little bit more about addiction, and I'm not part of any organized religion. But what I do know, and my expertise is I recognize diseases when I see diseases. And over the years, I've learned to recognize when genuine healing is happening. And so when I heard about this program, it really spoke to me because it spoke to me about real thorough healing of individuals in a way that was really quite profound. And when I look at how we incarcerate people, I see a disease process. And so this really struck a chord with me. And now that I've visited Homeboy, I can tell you that when you see people who are genuinely healing, the energy is really pretty unmistakable. And I went through a building there with hundreds of people, and the energy was just palpable. It radiated out to the blocks around Homeboy Industries. When I would see people walking on the streets, heading there or leaving there, everybody's wearing Homeboy Industries swag, and the greetings that we got and the welcome that we got, just the energy in the area was really pretty remarkable. So I think they really are the real deal. Some of you have the books from Father Boyle that I've loaned out. I encourage you to read them and pass them along. I will buy as many of those books as it takes to get everyone on the task force to have access to them. So I'm a believer that this can really work. Some facts and figures. Homeboy's been around for about 36 years. It's a program that kind of evolved in place. So it's geographically focused because that's where Father Boyle was at Dolores Mission Church. And interestingly, it started with a school. Speaking to what Chad identified, early access to kids who are struggling. What they noticed was that a large number of kids in the neighborhood were not going to school. Either they didn't feel safe there or they've been kicked out for behaviors, and they were just loose in the neighborhoods, in the housing projects. and they became recruiting targets for gangs. And so they started out with a school program and then evolved from there. Now they have, it's been 36 years. They make contact with about 9,000 to 10,000 unique individuals per year to provide services. They have their what they call their flagship program is a 18-month job training program where they place people in their social industries and teach them the soft skills that it takes to, obtain and remain employed. And then they have a whole suite of wraparound services, including, services to support victims of domestic violence, but also for people who are perpetrators of domestic violence. They have an art academy, they have case managers and navigators, they do education, GED programs, college prep, they have legal assistance, mental health, anger management, and training people for a variety of specific skills. And kind of unique to the gang situation, they also have a very robust tattoo removal program so that people who have visible tattoos can get those removed, which will aid with their employment. But, I think, and some other statistics. So for their program, and I've looked at various numbers for them over the years because they've been around for so long. And if you look at their numbers at people who have studied them at various times, it's really quite consistent over the decades. They have about a 70% rate of their graduates of their jobs program who do not reoffend and do not return to incarceration. So 70% is quite high, I think, compared to what is typical for this kind of work. They lose about 30% of their trainees to recidivism or, just failing to stick with it, which is actually fairly low for this kind of program. And of those 30% who they lose, about 12% of them then return after they get back out. So they do have a bounce back rate of people who still want to re-engage with the program. Their cost per year, and this is a pre-COVID number, is about $35,000 per year per trainee for their 18-month job training program. And so I would, to me, the numbers sound very successful. The costs do not sound high compared to the cost of incarceration and other modes of treatment that I've read about. But I think the really important thing about this program is that it's really makes overt kind of the unspoken emotional work that needs to happen, and they're very clear that this work is based in love and belonging and community and filling the emotional holes that people have from their upbringing. Most of their clientele are kids who have, absent fathers, domestic violence, substance use in the home, brought up on the streets by the gangs. So they're very, very high need folks. And one of the things that Father Boyle says in his books is that they practice what he calls reverse cherry picking, where they gravitate towards enrolling the people who are most difficult to work with, who are least likely to get services anywhere else. And that's what they're called to do. And, when I worked for the Job Corps, we had kind of a similar approach where if we could get someone who was influential and very heavily involved to turn a corner with us, that was often extremely successful in bringing other people along. So I think that may be part of their success, but really, and I know it's difficult to legislate or put in policy the need to love people, the need to give them unconditional belonging. But I think without recognizing that and without acting on that, you kind of cut ourselves off at the knees, because that's really what people need to heal. And so if there's a way that we can build that kind of language and culture into all of our efforts, I think it would really enhance our success. What I would love to see is not that we do this just at the programmatic level, but that we educate our entire community about people needing to belong, so that folks who have addiction disorders, people who are struggling with substance use, folks who have been previously incarcerated, are not viewed as other or disposable, but are viewed as no different than you or I, people who belong, so that everyone gets a second chance. I mean, we all need second chances. I've certainly had them in my life. And I just think that without acknowledging that reality, we really we cut ourselves off with the knees. And I know that's difficult to put into bureaucratic policy, but there it is. I think it's a reality. So with that, I'm going to hand it over to Mike, who has had contact with the Skagit program. So about, must be 8 or 9 years ago, Homeboy Industries recognized that there was a lot of interest in this kind of approach. And so they started a thing called the Global Homeboy Network, which is now in like 11 countries, and there's programs all over the world. I think there are 400 some programs in the United States and probably something in the double digits in Washington State. And close by in Skagit County, we have one of them. Mike?
Yeah, thanks, Dr. Wu. And yeah, full disclosure, same with Dr. Wu. This is not a subject matter expertise that I have as far as reentry programs and jail and all that. However, I learned about this program about 18 months ago through the Accountable Communities of Health, and sat on a review team that was awarding not really grant for money, it was performance, value-added performance money to organizations out there. And this group was able to get some of that operating money from the ACH last year. We're on that review board. And it was a really cool experience. We heard an in-person presentation from the local group. And like Dr. Wu said, this is actually sort of this is not probably the best word, but a franchise of the Homeboy Industries idea out of California. And the local organization is called One Parish, One Prisoner. And it's part of what's known as the Underground Ministries organization, where many churches around the region offer these reentry services for various types of prisoners coming back into the community. But this particular organization is Direct Reentry for Skagit County, has all local roots. And as Dr. Wu mentioned, this program is specific for the gang members in jail that are getting released. But the outreach doesn't start just when they're going to get released. This group is embedded inside the jail system for really kind of a long-term experience related to all the things that Dr. Wu mentioned earlier, which is inclusion and understanding and education and finding a way back. And sometimes this work begins, 10 years, 20 years prior to a person's release from jail. But once they get closer to release, and that's about a 2-year period, this group goes in, and it's generally a team of 7 that works with the prisoner to plan release. And they also work really closely with the families on the outside to prepare for that reentry into society as well, or into their community. And so these are comprised of reentry navigators. Most of them, if all of them, have a time in jail experience, jail and time with the gangs, etc. And on a side note, I put a packet, Jill put a packet in your email this morning that shows some photos and information about the local program. And so these reentry navigators engage about 2 years before. There's actually an application that you have to put in for, which I also included in the package, which I thought was interesting to look at, because this is an application from the prisoner that is saying, hey, I want to get into these services. I want to be part of this reentry program. And yeah, it's that healing, that journey of healing and transformation out of jail, gangs, prison, addiction, and reentry. They have that experience, are credible messengers to guide people out of this underground life. And they carry out this program work in what they call a deep chaplaincy and reentry accompaniment, right? Growing number of dozens and dozens of gang affected men now reaching out. And I'll say, when I saw the presentation about 1.5 years ago, super impressive. These are big men with lots of tattoos and a little scary looking. And, it was really interesting to see hear their language and their attitude and their direction with all this, because it's just not language that you would normally expect out of a person that has these long, deep gang experiences. So big gentleman type of people, but you could tell in their language that there was a real resonance among all of these themes that we talk about. Well, once again, inclusion and acceptance and reentry. So this is a long process on that relationship. It's a deep relationship as they describe it. And while there is some faith-based aspects to it, and it's a relationship, it's more of a relationship focused program than it is a faith-based sort of affiliation, if you will. So coming into this, you don't have to be religiously affiliated or have a specific religious alliance or whatever. They take you as a holistic, but they use a lot of the premises of faith-based community building for the reentry program. So I have not made a contact with this group in a while. But I really think it's very interesting that we've got this available and maybe at some point we might be able to hear from this group to see what they do locally. But they do have some great numbers on reentry acceptance, decreased recidivism, and easier, I don't know if it's easier, but at least pathways to getting back into the community and getting all these things back that you've lost while in prison. So just a great organization to think about. They do the same things locally, tattoo removal, getting your licenses back, getting insurance back, once again, integrating with your kids into your community, and ultimately create a new wholeness with this by decreasing fragmented communities as they come back into it. So that's the program locally, and I was just super impressed when I heard about it and wanted to bring that into the group. And with Dr. Wu's presentation, you can see that this is not an isolated network. It's a network that is growing and growing more across the nation and is showing success. So I'll leave it at that. And please check out your package. There's some great information in there. And there's 3 videos in there of the navigators and the work they've done locally. And they're fairly timely in the last year. So thanks for teeing that up, Dr. Wu.
Thank you, Mike. And thank you, Dr. Wu. This is a report back sort of on the first step of our exploration in the Behavioral Health Committee of this model. Mostly attractive because of its record of success, as Dr. Wu pointed out. How it translates, whether it translates to the Whatcom County environment and available resources here are questions we'll have to look at. And so I think we'll take this back into the committee and talk about its feasibility or what next steps of exploration might be. And so please look for that if you want to preview our agendas for coming meetings. But if there are a couple of questions now, again, I want to be aware of time constraints, but if there are a couple of questions now for Dr. Wu or Mike on this, be glad to entertain them. Okay, seeing none, thank you both for.
Hey, we've got a couple of questions, Stephen.
Oh, I'm sorry, Mike or Dan.
It's okay. I see Danny Carroll's hand up too. I'll be quick. So I just wanted to, for the benefit of all members here today, but especially the ones that are new here, peer-based reentry services is something that this is that Whatcom County's never been super strong on. There have been attempts to do it, but but having peers be at the center of how a person reenters and regains a sense of community is super important, and that work will need to be. I mean, there's some of it started in more of an institutionalized format, but not really in the not in the peer base. So I appreciate the presentation here this morning, and there's work to be done. And I don't know where that lives, if it lives in the Behavioral Health Committee for recommendation, or if it's Legal and Justice, or some combination thereof. But I just wanted to just for the benefit of the group that we have work to do here. Thanks.
Thanks, Dan. Danny?
Yeah, just had a quick question. Thank you both for reporting on that. What is as you were looking into it, what was the sort of infrastructure in terms of professional need that you saw that would be something that would be needed? So not just the peer side of it, but then also the workforce that's needed for that.
Right. So on the professional side, Homeboy at their main location, they typically I've seen different numbers over the years, but typically 30 to 40 professionally licensed counselors, therapists, social workers are in their staff for that clientele of 500 to 600 full-time trainees, and then the other 9,000 to 10,000 total contacts. They also make use of quite a few volunteers, so they have volunteer legal staff, teaching staff, They have some volunteer therapy staff as well, and there's as well as job training. So they usually run, I think the last number I saw was 200 to 300 volunteers who are there. And then, and then they have other non-professional staff. When I was there, it was interesting to me. A lot of the therapy seems to happen on the fly, passing in the hallway, just people greeting each other and having that community of contact. And there were a lot of people who were there clearly they weren't there for a class, they weren't there for an appointment, they were just there because it felt like the place they wanted to be, and they were just getting a hug and then going on about their day.
Beautiful, thank you.
Well, thank you again for covering that topic. And as I said, we will continue to take a look at this and try to flesh out our sense of whether this might have a place in Whatcom County as well.
Yeah, Stephen, before we move on, I'd just like to say I would welcome anyone on both committees who's interested. Contact me anytime. I'm happy to talk about it. I've got the library of Father Greg's books that I can loan out. I've got a list of podcasts and videos of him speaking that are a quick, easy way to introduce the subject. And I would love an expression of whether or not this is of interest and worth pursuing, or if I should just drop it and move on.
Are you asking for that right now, Dr. Wu?
No, it doesn't have to be now.
Okay. Arlene, I'm going to put you on hold while we move on a little bit, if you don't mind. I mentioned that we had some new members on the committee, and both of them are in attendance now, as well as a fairly new member, Lieutenant Nelson from Bellingham Police. So I'd like it if Lieutenant Nelson, Jen, and Amy would turn your cameras on and introduce yourself, just your name, affiliation, and your interest in one or both of these committees. Kyle, you want to start out?
Sure. My name is Lieutenant Kyle Nelson. I've been an officer with the Bellingham Police Department for a little over 18 years, and I'm one of two patrol lieutenants for our department. So we obviously interact with the Behavioral Health Committee and substance use disorder folks pretty regularly.
Great. Thank you, Kyle. Jen?
Hey, thanks. I'm Jen Lockwood. I'm the Executive Director at Bridget Collins Family Support Center. I've really been meaning to participate for a long time, and as entering my third year as Executive Director, finally digging myself out and trying to participate. So my apologies for my lack of participation prior. And my interest, obviously, being the Executive Director of a organization that serves youth and families, and many of which have interfaced with people that are incarcerated, and also as a licensed mental health counselor, I have a lot of really specific interest here. So thanks for having me.
Thank you, Jen. Amy?
Yeah, good afternoon, everybody. Amy Hockenberry. I'm here as a private citizen, but my background in history, I've been living until 3 months ago in Whatcom County. For about 7 of those years, of the 14 years, was in behavioral health and substance use disorder prevention, as well as mental health promotion, and then 7 years focusing on data and data systems. And 10 of those was at the Whatcom County Health and Community Services. So I've moved on to work at the state level, so I'm just really excited to be able to come back and support my community in a new and different capacity.
Thank you, Amy, and welcome to both of our brand new members, and thanks for attending. Dan, I'm going to turn it over to you for the next item.
Stephen, I'm sorry if you were talking to me, I didn't catch it.
I'm sorry. I think you're on for the next item, the Dijval Lake Wellness Center.
Okay, thanks. So I'm going to ask Melora to help kind of tag team this one. She's a little more closer to the actual operations part of it. Is everyone familiar with the Dijval Leach, the gift that has been given by the Swinomish tribe of the 2 mobile medical units? Okay, I'm seeing not a lot of head nods. I'm just going to give a very brief overview. About a year and a half ago, the Bellingham City Council voted to make public drug use illegal and in response to the fentanyl crisis. And we requested some off ramps to be provided because there wasn't a good system for people were not going to get locked up for a misdemeanor. They would probably stack up court dates, and it would just kind of become a legal nightmare issue. So we were kind of looking for solutions, and one of those solutions was the community court system that we are just now getting up and ready to launch, so we can at least provide some services for folks at the municipal court level. So that's the city court level. And in this process, the city council was contacted by Beverly Keys, Dr. Keys, and Senator Leon John from the tribe. Beverly Keys is the executive director of the D12H Clinic, and Senator John is a 20-year veteran of their Senate. And we had a great meeting, and we talked about all the things that the clinic does. Went down several times to tour the clinic and brought down many people. The last time I was there, I was with the mayor and the county executive, and several county staff members and city council members have gone down. And during that process, they reached out, the tribe reached out and said, look, we want to give you 2 mobile medical units. They cost about $1 million total. They would provide methadone and Suboxone treatment options. We had to figure out a place for them to be parked. They have to be plugged into a building, and that building also would need to have private offices for outpatient treatment options to just help people kind of intake through the process of receiving those daily doses of the opiate agonists that are being provided to help people kind of wean off of the fentanyl in particular. And so that relationship developed, and Whatcom County Health Department, Melora, Director Erica Lautenbach got involved and their staff, and it became clear that this is happening. And so Swinomish Tribe also hired up 26 FTEs to support this program. Every position from security to clinicians and doctors and nurses and such. So very, very dedicated program here. And my understanding is that the contract will be signed at Division Street, and that's where the location is. A Division Street facility behind the Ann Deacon Center for Hope. The lease contract would be signed, I think, in mid-January, and then there would be some kind of retooling of the interior of the building, and then they would open up as soon as they can after that, and knowing that construction takes forever. But hopefully they'd be up and running within month and a half or 2. The ability to treat at these 2 mobile medical units is up to 400 plus patients per day. Sorry, I'm getting over a cold. 400 patients per day, every day. And so that's great news. We have one larger provider here, and it's Bellingham Comprehensive Treatment. It's on Northwest. It's run by Acadia Healthcare. You might want to look, do just a quick Google search on that one. The New York Times article a couple days ago provided some light on that. So the introduction, I guess, a long way of saying the introduction of Swinomish D12H Clinic is, and by the way, these services don't cost anything to the person that is receiving them, and they can also receive services back at the clinic. And so if they need dental, medical services, if they are looking for counseling or group therapy sessions, that's all available to each person that goes through the door at these mobile medical units, and it's all at no cost. And so this is an incredible gift beyond the dollar value of what the tribe is providing. There's I think a broader lesson that I've learned over the past year and a half is that thinking about what constitutes community does not mean that there's like a border wall around the edge of it. that the way that the tribe thinks about community, they think very broadly. 70% of the people that go to the clinic are not tribal members. They have shuttle buses down to Snohomish, up to Concrete, over to Anacortes, and up here. And so there's that's a lot of really good news that's happening pretty quick here. And when I think about that, the way station, the mission, it feels like we're gaining traction on some of these more intractable issues. And I'll go ahead and stop there. And Melora, I don't know, I probably missed a bunch, but
No, Dan, you were spot on. I don't have anything to add, but happy to answer questions about specifics about the services that will be provided.
Peter, go ahead.
Melora and Dan, what sort of are there any barriers to getting started and to the program continuing? I mean, I've been following this all the way along, but I really don't know how long the commitment is for. Any details around those I'd be interested in. Thanks.
Yeah, I'm happy to take a stab at that. And Dan, please add if I'm missing anything. The lease that will be confirmed in mid-January by County Council is a 3-year lease. And so we're starting kind of with this 3-year commitment. I will say that this is at the Division Street campus, which already has the Ann Deacon Center for Hope, which is our crisis stabilization center. And then just adjacent to that is where we're building the 23-hour crisis relief center. And so we're starting to, wanting to have community conversations about this Division Street campus being a behavioral health campus where people get a variety of different services in one location. And so I mean, our hope is that Digwal-Leach would continue to provide this service long term. Also working with our tribal partners in Whatcom County. Lummi is in the process of getting their own MOUD services as a service that they can provide to tribal members. Swinomish and Digwal-Leach will be open to everyone. So we're gonna start this out and hope that it is here for a long time. So that is the intention.
And I would just add to that real quick before Heather, that I think it's important for the Behavioral Health Committee and the task force to think about, do we have a vision that we can recommend or make a recommendation to the county for what the Division Street facility could look like? I mean, Melora just mentioned a campus. I think that would be amazing to have a behavioral health campus, and that's where it's trending right now. So the work, the like 3/4 of that building will be moved to La Bounty because that won't be needed anymore. So what could we do there? Could we add in medical and dental services, or I just don't know at this point, but I think that there's a lot of possibility. To answer your question, Peter, what barriers? There's been some concerns about transportation, and I just want to, while Melora's on the call here, so Skip Williams serves on the WTA board, and he's reached out to Les Reardon's, I think is the name of the executive director, and in hopes that we could provide some kind of like shuttle services in addition to the fixed route. Those conversations need to happen, and I would urge us to think about the opening of the mobile medical units as sort of like a phased approach, like a soft launch. And so we can get some of those, transportation in particular is going to be the challenge, because it is where it is. And believe me, there was a lot of searching around where we could locate those mobile medical units within the city. And they're big and they require very specialized like adjacent services when it comes to those that outpatient treatment, kind of smallish, but still needed. So, but yeah, I think that that's kind of one of the main things, and I think it's getting sorted out. And Melora had some good points in your email that you had sent to me and some others before about some options on both transportation and outreach.
Yeah, I can just close that loop really quick before Heather goes. Transportation, it will continue to be something we work with WTA. Degual-Leach is also considering having some local transportation routes here in Whatcom County for this new service, so that could be a possibility. The Response System Division has a full-time staff that only does transportation for vulnerable populations, and that individual will have this as a new location. That staff is also co-located at this division campus, so that will be a good partnership. And then so many of our service providers are trying to get their own transportation services. For example, the homeless outreach team provides transportation. Not all of our service providers do, but many do. So we'll be trying to, give out free bus passes. But Dan's right, it will be a phased approach.
Heather?
I am so excited about this and just want to thank you for doing all of that work to create this partnership. I know, Dan, you were a huge part of that, and I'm sure there's lots of people that were that I don't even know. But just, it's really amazing. And I love what you said about how it has redefined some of how you're thinking about community outside of borders and the gift of Degual-Leach and Swinomish. And a few questions I had, I wanted to just underline, I think that another priority of the IPRTF as part of that implementation plan for the Justice Project is looking at diversion programs and like how effective they are they operating how we were hoping? And also there's like a broad scale, what facility needs do we have? And so I just want to connect those dots, not that there's an extra question there, but that this fits into those things really well as an update and will be important information for us to remember when we get to that work. And I'm curious about budget also as our IPRTF role around recommendations to county council around policies, and if there are any policies or budget things around this partnership that either now or in the future you want to make sure the committees or the IPRTF is aware of so that we can be formulating recommendations to county council really well and supportively for you guys. And then the third thing is I was wondering, maybe Melora, you might know, where does Cascade Medical Advantage fit into the whole landscape of the medical opioid use disorder treatment stuff? Because they're a fabulous partner, I understand, and they're also doing some great work. So it'd be good to just, what is that landscape?
I'm happy to take the landscape question. So thank you, Heather, for bringing that up. Degual-Leach is bringing a new service to Whatcom County. That adds to a continuum of services for substance use disorder and opioid use disorder that already exist here and are functioning every day. Dan's point is that we at this time, only have one other provider that is doing methadone. And that's that Comprehensive Medical Treatment Center. It is a for-profit national company, very different than having a regional tribe providing services to our local community. But they do see a lot of people, the other methadone clinic. And so one of the advantages of having Degual-Leach come up is their trauma-informed approach. They're really person-centered care, and they're going to do wraparound services by providing connection to other services, where our Bellingham Comprehensive might just only be doing methadone, MOUD, and some addiction counseling. So it's an expansion of that. I will say medication-assisted treatment and medication for opioid use disorder is also available to our community members at Cascade Medical Advantage or CMA, and they've been doing that work here locally for a long, long time. Dr. Adam Cartman has kind of led the way in the state, actually, to get methadone and MOUD services across the state. So CMA is very much involved. CMAR also has a really robust MAT and MOUD program that's led by Dr. Shannon Bosted. So his work will continue at that clinic. Unity Care is kind of dipping their toe into this work and seeing what they're going to do. And then, of course, we've also been partnering with Peace Health, St. Joe's Hospital, and emergency department providers with the ability to do buprenorphine induction in the ED when someone comes in with an opioid use disorder, and then they would make a referral to follow-up services and coordination after they leave the ED. So your point about CMA is that we already have this continuum, and DeGwal is going to bring this very helpful service that will add to the existing continuum.
Dr. Wu, I'll take a quick question. We have one more report we want to try to squeeze in.
Right. This isn't really a question, but just a quick comment. Actually, Family Care Network clinics are getting ready to dip our toe into that as well. So there's a training for us in December, and we're hoping to start offering services in January.
And we owe a thanks to you for your advocacy in-house at Family Care Network there, I think, and Dr. Safford also. So moving on with the agenda, Raylene, do you want to introduce Caleb and the topic, or do you want to should we turn it over to Caleb to talk about the behavioral health pilot program at the work center and the reentry demonstration initiative in the jail?
Let's turn it over to Caleb. Thank you.
You're on, Caleb.
Hello, everybody. And for those who joined a little bit later in the discussion, my name is Caleb Erickson. I'm the Chief Corrections Deputy for the Sheriff's Office. I've got a whole bunch of stuff to talk about, and it can be a little bit long-winded, so I'm going to try and rush through this a little bit. So if you will bear with me, I will attempt to do a slideshow. Let's see here. I'm hoping you can see my screen at this point.
We can.
Excellent. So the first thing we want to talk about is our pilot program for our mental health unit in the work center. So as you may or may not be aware, up until recently and for quite a long time, mental health in the jail was really focused on crisis intervention, suicidality and finding diagnoses to help people in crisis. But we've had, and there's been community support for a desire to turn the corner towards intervention and other supportive management from a behavioral health standpoint. And so about a year and a half ago, I started to dream up ideas about what possibilities could exist in, actually having some form of semi-therapeutic environment, having some potential for making some real change, pun intended, in the landscape of people's lives who are incarcerated. And through a process of working with our partners with Lifeline Connections and resources from the Sheriff's Office and working with the Health and Community Services folks, we developed a 6-week program to pilot and in one of the units at the work center. It was really focused on reentry. We had 4 days a week of counseling services, reentry work, and peer group work that was all focusing on helping them to reduce the likelihood of recidivism and to create a better path for their lives. We had 5 graduates of the program. We started on October 14th of this year. Before that, we did some groundwork to paint the unit, to come up with some wall art that gave a little bit of hope for the people who are literally housed in this space. And we turned in the multi-purpose room into as much of a therapeutic environment as we could. And so we took out the tables that were bolted to the floor in one of the units. We painted it a blue color, which was selected as a calming color from some of our folks with Lifeline Connections. As you can see, we purchased new tables and chairs that can be moved and stacked in case that there were things, activities, and other things that need to be done in the space, the shared space in the unit. And we reorganized the bunks so that they were not lined up next to each other. And again, this has been received really well from the people who are incarcerated as well. And then we really began to spend those 6 weeks working on the process, and truly transformational change was achieved for all of the 5 people who were involved. We can report really, really good success on the program, and we are going to be staying connected with the folks who are involved in this initial cohort. We'll be tracking their progress as they go throughout the rest of the incarceration setting that they're in right now and in the future. We intend to have a process, a cohort started for women-only population after the beginning of the year. We're also working to retrofit another unit with similar outfitted tables and chairs and a mural. I'm going to change directions rapidly and talk about the HC reentry initiative, and I'll take questions for either or both at the end. So if you don't know, the Sheriff's Office applied to be a part of the Healthcare Authority of Washington State's reentry initiative. It used to be called the 1115 demonstration waiver, but they've changed the name to make it simpler. The goal of the initiative is to provide funding to agencies like the Sheriff's Office to reduce recidivism, creating a holistic approach, addressing the gaps for folks who are incarcerated, specifically dealing with mental health and substance use treatment options, and then lowering costs for the community. And what it is really intended to do is to provide Apple Health or Medicaid funding for folks who are incarcerated, to allow providers and Sheriff's Office or people to bill for those services for people who are incarcerated. So we are in cohort 1. There are 3 cohorts laid out by the initiative. There's $2.5 million in the award for Whatcom County. There are 5 milestones, and $1 million of the award will be specifically focused on IT-related infrastructure and projects. We are on milestone 2, so we've completed milestone 1. We're on milestone 2. Next steps is what they call capacity building application, which includes an anticipated budget for how the award funds will be used, and we're working on completing an attestation form. There are a number of components to it. I'm going to go over just a couple of them because I think that they're instructive for this discussion. So the attestation form requires that everybody who is admitted into our incarceration facilities must be screened within 24 hours of intake. We're encouraged to screen folks who are not going to stay for more than 24 hours, but it is not mandatory. All applications must be submitted to Apple Health within 2 business days of intake. We have to update contact information or address information, as the incarceration progresses, so that Apple Health can maintain connectivity with those individuals post-release. Reentry service providers, including pharmacies and in-facility staff, must be enrolled with the Healthcare Authority, and they must also be credentialed with every Medicaid managed care organization within a year of go live. So these are easy things to say, but there are a lot of steps involved in those two things. And then some of the constraints that we have for the phasing of the project, which is, they initially laid this out in a timeline fashion, is it takes about 10 months for a provider to gain enrollment with HCA. So even if somebody applied today, it could take a number of months to get that processed. And they intend to have a claims clearinghouse for all participants in cohort one ready by November of 2025. So what that means for us is we are likely targeting this. We're likely targeting this November to January of 2025 and later start. Because we have a number of needs related to some of the steps along the process, specifically the clearinghouse, the provider enrollment, and so forth. So the conditions that they've set out so far is we have to have a clearinghouse to bill. We have to have the majority of providers not known to provider one enrolled with the HCA have to be added to the enrollment queue. And then we have to have some strategies identified for meeting the program requirements. And so all of those things lead me to essentially go live in late 2025, if not later. We will begin training in January for how to search for enrollment criteria, how to look into what the process is for enrollment. And then we've got to make a selection for when we want to go live by February. And then we aim to have milestone 2 accomplished by the first quarter of 2025. And we are going to be partnered with healthcare record software called Epic sometime in 2026. They don't know exactly when that is yet, but we anticipate going live at some point in 2025 or later. I have all the milestones listed out here, but I wasn't going to go over them unless people are really interested in seeing that. So let's see here. I will stop my share and take questions.
Caleb, we're up against the time wall here. I don't see any hands up from who I can see. Peter, is that you?
Yes, I just have to say, Caleb, thank you so much for putting that pilot program together. It was exciting to see such a thing in Columbus when we were there, and I assume that there was a spark of you're seeing it there and bringing it about here. I just am so proud of you guys for carrying this off with Lifeline, and I wish we had more time for questions, but I just really wanted to say thank you. I really applaud you.
It seems like a very comprehensive startup and road laid out ahead of you, Caleb. I'm sure we're going to want to have you back for quarterly meeting update reports on how this plays out. Brian, if you can do this quickly, we've still got public comment to squeeze in.
No, I just wanted to say, Caleb, this sounds like a fantastic program, and I definitely would like to have you come back, say in 3 months at our next joint meeting, and we'll have more time to discuss this.
Absolutely. Thanks, Caleb. Jill, I think we should move to public comment since we're a little bit over time, and I apologize to people as much as we try to adhere to the timelines, we blew it again. Sheriff Tank. Tank, do you have your hand up?
Yes, Hey, I'll be quick. I just want everyone to know that last Friday, we graduated 20 students from the Crisis Intervention Certification course. 12 of those from the Sheriff's Office and 8 other students from other jurisdictions here in Whatcom County and Health and Community Services. So hopefully in 2025, we'll have 2 more classes, but we have 12 more deputies on the road that's certified in crisis intervention to help folks.
Thank you. That's really encouraging progress. This has been a positive meeting we've had here with a lot of the information transmitted. Jill, do you want to call for public comment, please?
Yes, we have 2 attendees. If either of you would like to speak to the committees, please virtually raise your hand now. No hands are raised. And Peter, I don't see anyone with you in the conference room.
No, it's just me.
Thank you, everyone.
And thank you, everyone, from me, Dan, and Raylene as well. Thanks for staying a few minutes overtime. And we're adjourned for now, and we'll see you next time.